corticosteroids. It was asked for 3 marks. Now, when the question was asked for mention the adverse drug reaction of corticosteroids, basically it was focusing on adverse drug reaction because adverse drug reaction due to corticosteroids is one of the uh, extension of the clinical effect of corticosteroids. If you ask someone adverse drug reaction of corticosteroids and he's able to explain it, you can simply know that he also knows the clinical effect of corticosteroids on the human body. Basically, an extension of the clinical effect of corticosteroids leads to adverse drug reactions. Can you hear me? Yes, no.
Yes, sir.
So we'll start with our case. A 19 years old man of anorexia, fatigue, loss of 8 months ago, and weight. The physician finds hyponatremia, hyperkalemia, and acidosis and suspects Addison's disease. Later, she was diagnosed with Addison's disease. Patient be treated. What precaution should he take? Can someone tell me the answer for this Addison disease? Okay, basically from this, what we can find out is that Addison disease is an autoimmune disease. So it is an autoimmune disease. The patient who has this Addison disease is kept on corticosteroids. Corticosteroids basically which has glucocorticoid activity as well as which has mineralocorticoid activity. So this patient was kept on hydrocortisone. Although this drug hydrocortisone has both glucocorticoid activity and mineralocorticoid activity, still we need to add one more mineralocorticoid, that is fludrocortisone. The corticosteroids are produced by the adrenal glands, basically the adrenal cortex. On your screen, you have the structure of adrenal gland, which has been divided into two layers. One is the cortex, the next is the medulla. The cortex can further be divided into zona glomerulosa that produces mineralocorticoid known as aldosterone. Then you have zona fasciculata that is just below zona glomerulosa that produces your glucocorticoids, that is cortisol. Below zona fasciculata you have zona reticularis that produce androgens, and in those testosterone, and the next is estrogen. Below the cortex you have the medulla, it's different. CRH, that is corticotropin releasing hormone, that is produced by hypothalamus, or either due to less concentration of ACTH, or maybe due to any kind of defect in adrenal cortex, which ultimately can lead to low level of glucocorticoids in the body, leads to a disease known as Addison's disease. Contrary to this, whenever the level of corticosteroids are high in the serum, it leads to a syndrome known as Cushing's syndrome. Now, those two basically, Addison disease and Cushing syndrome, were associated with glucocorticoids. But what about mineralocorticoid then? The mineralocorticoid, which is aldosterone, it is associated with CRH, it is associated with ACTH, but basically its secretion is determined by renin-angiotensin aldosterone system. So the level of potassium in the serum as well as the level of angiotensin in the serum determines the secretion or the level of aldosterone in the human body. There are various clinical effects of glucocorticoids, but out of those various clinical effects, there are only two effects which are important for you to remember and important for the examiner to ask. That is its effect on metabolism and its effect on immune system. Mineralocorticoid has activity regarding retention of sodium. Coming to the sex steroids. In case of males, testosterone is present in his body throughout his life. Testes as well as the adrenal glands are responsible for production of testosterone. In case of females, before puberty and after menopause, the ovary is less likely to produce the sex steroid, which is estrogen. In such scenario, the adrenal gland is responsible for production of estrogen. At the same time, both testosterone and estrogen can be present in male as well as in female. But in males, estrogen is comparatively less in amount. In females, testosterone is comparatively less in amount. But both of these hormones are present. Now we move on to the pharmacokinetic parameters of the natural cortisol. Their half-life is very less. It stands around 60 to 90 minutes. Most of the cortisol is metabolized in the liver. When cortisol is secreted by the adrenal cortex, they are basically in bound form. It generally binds to the globulin. Most of the drugs that we consume, they bind to plasma protein, which is albumin. But corticosteroids, which are produced by the body, rather than binding to albumin, binds to the plasma protein known as globulin. Now we move on to the pharmacodynamic characteristics of corticosteroids. Steroids are lipid soluble. They are so much lipid soluble that they can be applied topically and it can enter the systemic circulation. They can be given via oral route. They can be given via parenchymal route. But the natural corticosteroids that is produced by the adrenal cortex, generally they bind to this globulin known as cortisol binding globulin that is responsible for its transportation to its respective site. When it reaches the particular cell, the steroid is released. It enters inside the cell because it is lipid soluble and binds to the steroid receptor. This steroid receptor is basically inactive because of binding of HSP, that is called heat shock protein 90. Because of binding of HSP90 to the steroid receptor, that receptor is initially inactive. When steroid binds to this receptor, the HSP90 molecule dissociate and two molecule of steroid receptor dimerize together. So when they come together and form a dimer, this enters inside the nucleus where it binds to the DNA, specifically in GRE, that stands for glucocorticoid response element. Upon activation of GRE segment in the DNA, DNA starts to produce mRNA. mRNA then leaves the nucleus into the cytoplasm where it is converted to a protein that is responsible for producing various kinds of cellular responses. The response can be different depending upon the cell types. For example, for bronchodilation or for vasodilation, corticosteroids are required. In the absence of corticosteroids or the cortisol, the bronchial muscles and the vascular muscles do not respond well. This is a physiological effect. The other name for this effect is permissive effect. Seems that cortisol is responsible for giving permission to the vascular muscles as well as to the bronchial muscles to relax. Metabolic effect. No matter what, cortisol has only one aim, and that aim is to supply glucose to the brain during stressful situation. Whether you are starving, whether you have anxiety, or whether you are in a situation in which you have severe stress. In such situation, the main aim of corticosteroids is to supply glucose by any means. We mean it can produce some toxic effect in the body in order to produce glucose. It can produce catabolism of the muscles. It can produce lipolysis. It can inhibit absorption of glucose into the other cells just to supply sufficient amount of glucose to the brain so that the human body can survive. So that is the main aim of corticosteroids. Because the corticosteroids is targeted to enhance or to maintain the level of glucose, and to produce that effect it needs to produce or it needs to break down muscles and other structures in the body, which leads to the adverse drug reaction of corticosteroids. These cortisol can inhibit peripheral glucose uptake. They also enhance the release of amino acid from the muscles by catabolism and promote gluconeogenesis. So in this way, the volume of muscle decreases. The person becomes thin. Now, when the protein molecules are diverted towards increasing the level of glucose, when at the same time cortisol is inhibiting absorption of glucose by the other cells. Both of these procedures ultimately leads to increase in level of glucose in the body. When the level of glucose in the body increases, the body secretes a hormone known as insulin. But this time, the role of insulin is not to convert glucose to glycogen, but this time the role of insulin would be to promote lipogenesis, that is, formation of lipid molecules. There are certain sites in the body where there is lipolysis, but comparatively, lipogenesis is more than lipolysis. It is because of lipogenesis that we have a syndrome known as Cushing syndrome, which is a typical feature of high serum concentration of cortisol. Cortisol, it also has catabolic and anti-anabolic action. It breaks down the muscles to decrease its mass. With the breakdown of muscle, the person will have weakness and even the skin will become very thin. The thinning of the skin is to that extent that even the veins and arteries sometimes become visible, which is known as stria. Anti-inflammatory and immunosuppressive effect. Now, if there is one thing that you should remember among the clinical effect of glucocorticosteroids, then that effect is anti-inflammatory and immunosuppressive effect. Prime Minister KP Sharma Oli also takes glucocorticosteroids for this anti-inflammatory and immunosuppressive effect. We use corticosteroids for anti-inflammatory and immunosuppressive effect. Most of the indication of corticosteroids are are focused on its anti-inflammatory and immunosuppressive actions. This effect is seen due to its effect on the leukocytes and its effect on the inflammatory mediators like prostaglandins and leukotrienes. Now, among these two effects, its first effect on leukocyte, we find that corticosteroids they increase the concentration of neutrophil in the plasma. But why does it increase? Corticosteroids they decrease lymphocytes, basophils, eosinophils, and monocytes. But why and how? When it comes to neutrophils, corticosteroids allow influx of neutrophils into the blood from the bone marrow, and it decreases the migration of these neutrophils from the blood. That is why there is more of influx and decreased efflux, which leads to increased concentration of neutrophil in the blood. Whereas these corticosteroids allow efflux of lymphocytes, basophils, eosinophils, and monocyte from the blood into the lymphoid system. Because of efflux or movement of lymphocytes, basophils, eosinophil, and monocyte away from the vascular system, there is immunosuppressive action, which is helpful during transplant or graft. Corticosteroids also have anti-inflammatory action. This anti-inflammatory action is because of its ability to inhibit the enzyme phospholipase A2. They inhibit phospholipase A2, thus reduce the synthesis of arachidonic acid, which are the precursor molecules for synthesis of prostaglandins, leukotrienes, and platelet activating factors. Here in this picture on the screen, these are the lipid molecules which are present in the membrane. These phospholipids are broken down by enzyme that is called as phospholipase A2 into arachidonic acid. This arachidonic acid is later converted by cyclooxygenase enzymes into prostaglandins and leukotrienes. However, the synthesis of this prostaglandins, arachidonic acid can be inhibited by corticosteroids as it helps to inhibit or inactivate this enzyme phospholipase A2 by producing a protein known as annexin 1, whose other name is lipocortin. So corticosteroids produce lipocortin or annexin A1 to inhibit phospholipase A2. When phospholipase A2 is inhibited, arachidonic acid is not formed, and along with that, other molecules of inflammation, which are prostaglandins, leukotrienes, and platelet activating factors, are not formed. Therefore, corticosteroids helps to produce anti-inflammatory action as well as suppress leukocyte function. Those two actions are important from therapeutic uses, whereas other uses can lead to some adverse drug reactions. For example, prolonged use of glucocorticosteroids can produce depression in patients. Corticosteroids can also suppress ACTH because of its negative feedback action, which can also inhibit growth hormone, which can lead to diminished growth in children if you give corticosteroids. It can also inhibit thyroid stimulating hormone and produce hypothyroidism, as glucocorticoids also inhibit conversion of T4 to T3. Corticosteroids can also inhibit luteinizing hormone and inhibit reproductive functions. Not only that, corticosteroids can also produce peptic ulcers. This is because of its ability to suppress the local immune reaction against the bacteria H. pylori. So patient or people who already have peptic ulcer or who are prone to peptic ulcer should avoid corticosteroids. They also antagonize the effect of vitamin D, ultimately leading to osteoporosis, which can lead to pathological fracture. Therefore, when administering corticosteroids for a longer duration, serum level of calcium should also be checked. One interesting effect of corticosteroids is its effect on fetal lung maturation. Corticosteroids helps in production of surfactant, a molecule that is required for the lungs to expand. When lung is able to expand, the fetus can breathe inside. So corticosteroids helps in prevention of respiratory distress syndrome in small children, as it helps in production of a molecule that is known as surfactant. Okay, question answer round. Richika Dongun, are you there?
Yes, sir.
Okay, all of the following are correct about steroids except
Number three.
no. Guess again.
Number four. No, sir. Wait.
No. Guess again.
Number two.
Aina?
Yes, sir.
Okay. So we said that corticosteroids are required for various functions, and among those various functions, corticosteroids are responsible or they allow permissive effect for smooth muscle relaxation, which means vascular smooth muscle relaxation, bronchial smooth muscle relaxation. So corticosteroids not only inhibit inflammation by inhibiting the release of arachidonic acid, but it also permit vascular membrane permeability, leading to vasodilation, bronchodilation, and also helps to maintain glucose supply to the brain by increasing the level of glucose in the body. Prince Mohato, is he back? You answer. Glucocorticoids act in inflammation by. Very good. It increases lipoprotein. Could you tell me another name for lipoprotein? Sorry. Okay, I think I heard Alex in one. Okay, thank you. So that was about the cortisol that is produced by the human body. Summarizing it once, it is responsible for bronchodilation, it is responsible for vasodilation, it also helps to suppress inflammation, it also helps to suppress immunity. Although suppressing immunity is not good, but whenever it is a case of kidney transplant or a skin graft or any other transplantation of a particular tissue and organ, immune suppression is desirable. Then it is also responsible for maintaining constant supply of glucose to the brain whenever you are starving. But at the same time, it is also responsible for inhibition of growth. It is also responsible for abnormal reproductive functions. It is also responsible for hypothyroidism. But body balances everything very nicely, which means that our body does produce cortisol, but we are not suffering from any kind of reproductive disorders. We are not suffering from hypothyroidism, and we are not suffering from diabetes mellitus. So body balances out everything. The problem comes when we give synthetic corticosteroids. But why do we give synthetic corticosteroids? It is to produce one typical action, that is anti-inflammatory and immunosuppressive action. Only for this, basically we are giving corticosteroids. But this anti-inflammatory and immunosuppressive action, it is a non-endocrinal. Means suppose you happen to develop a pathology, a disease. In that scenario, you give synthetic corticosteroids. But what if you're born with a disease? What if you have a defect in adrenal glands? What if your pituitary gland has a defect? What if the hypothalamus has a defect? What if there is a tumor in the body which produce some kinds of steroids or CRH or ectopic ACTH? So we have to give corticosteroids in that endocrinal causes also. So basically clinical point of view, we have endocrinal use and we have non-endocrinal use. And among the non-endocrinal use, most of the corticosteroids are used for anti-inflammatory and immunosuppressive actions. Now, we said about cortisol that its half-life was only 60 to 90 minutes. But the synthetic one needs to be longer acting. Just like cortisol, they are easily absorbed, but their half-life is pretty long. They are at least 50% longer half-life than the natural ones. The synthetic corticosteroids also have the similar mechanism of action. They bind to the same globulin, that is cortisol binding globulin. They approach the same cells. They bind to the steroid receptors, which was initially inactive because of binding of HSP90. When this synthetic steroid bind to the receptor, HSP90 molecule dissociate, and two of the steroid receptor molecules they dimerize, they enter inside the nucleus, and they activate a particular site that is called GRE, that is glucocorticoid response element, that is responsible for production of mRNA, which leaves the nucleus into the cytoplasm, and in the cytoplasm it is converted to a protein, and that protein produce a response. So similar to natural cortisol, synthetic corticosteroids also follow the same pattern. But the difference is that while the natural cortisol have glucocorticoid and mineralocorticoid activity in the ratio of 1:1, the synthetic may not have the same effect. Some of the synthetic corticosteroid might have very high amount of glucocorticoid activity and minimal amount of mineralocorticoid activity, whereas some corticosteroids might have very high amount of mineralocorticoid activity and least amount of glucocorticoid activity. So this activity varies from steroid to steroid. Here we have a list of corticosteroids. On your screen, top left corner, we have short to medium acting corticosteroids. We have hydrocortisone, cortisone, prednisone, prednisolone, methylprednisolone, miprednisolone. As we move towards the right, you have the anti-inflammatory action. We have particular topical activity, because these are also available for application on the skin surfaces. You have some aldosterone activity, that is salt retaining activity, and various route of administration of these drugs. Now on the top you have the least potent corticosteroids like hydrocortisone. As you move downwards, you will find that the strength of corticosteroids increase, mostly the anti-inflammatory action. Triamcinolone, paramethasone, fluprednisolone are more potent, whereas betamethasone and dexamethasone are very potent. The potency of betamethasone varies from 25 to 40, which makes it a question for MCQ lovers. That is, which is the most potent glucocorticoids? 30 lies in the range between 25 to 40. If betamethasone is in the option, the most potent is betamethasone. If betamethasone is not in the option, the most potent is dexamethasone. Here you have flutocortisone, which is a mineralocorticoid. It has slight amount of anti-inflammatory action, but its mineralocorticoid action is very high, that is 250 compared to other kinds of corticosteroids. So we'll end our class for now. We'll meet in the next class. Thank you.